Most women, when they conceived, are filled with joy. Their families eagerly anticipate the cry of a healthy newborn and the smile of a proud mother. But for too many, that joy is tragically cut short. According to UNFPA, every 2 minutes, a woman dies from complications related to a pregnancy or childbirth. All too often, our baby does not survive either. But behind each number is a face, a young mother with dreams, a hopeful family waiting for a newborn who never gets to cry. These are not just statistics. These are lives, and they matter. Here in Gombe State, where too many families have buried mothers and babies in silence, a new effort is taking root. It's called the Maternal and Neonatal Mortality Reduction Innovation Initiative, MAMI. Still in its early stages, MAMI brings together communities, governments, and partners to co-create solutions that are locally relevant and truly life-saving. Good day, I am Rebecca Caleb Minor, and this is Health Talk on GMC TV. With us today are Dr. Dayo Adeyonju, the National MAMI Coordinator, who is visiting Gombe for the ongoing 5-day co-creation workshop. Doctor, you're welcome to Gombe.
Good morning, thank you.
And we also have our own Dr. Siraj Abdulkarim, who is the Gombe State Swap Coordinator. Doctor, you're welcome.
Good morning, and thank you for having me.
Doctor, welcome to Gombe once again. I hope you've been enjoying for the past 5 days or so in Gombe. I hope you've been having a nice time interacting with our clients and stakeholders.
Yeah, thank you.
Doctor, I'll start with you. MAMI is generating a national interest nationwide, but many still don't fully understand what it is. Could you please briefly explain what MAMI is and why it became necessary at this point in time?
Okay, just like you said when you were doing the introduction, when you mentioned that Nigeria contributes, close to 20% of the global maternal death. Unfortunately, we're just less than 10% of the total global population, so which makes it very, very unacceptable, And you said every 2 minutes, a woman will die somewhere as a result of pregnancy related. So MAMI, maternal and newborn, mortality reduction innovation initiative was then launched by Mr. President, as a country strategy actually to crash, maternal mortality and newborn mortality in the entire country. And of course, MAMI, from the name, it's clear that one, if we talk about reduction, it means that something must be unacceptably high. If we talk about innovation, it means there are things we have done in the past. We totally have to depart, from what we used to do, that didn't give us the desired result, to what we now agreed, will help us to really, crash this needless death of the mothers and the newborn. And you will recall, if we look at it in just last 10 years, or even almost 18 years, our maternal mortality has been oscillating, between 545, 576, and then the last one was 512. To tell you that our efforts, even though we had so many interventions, we didn't get the desired result. That's why we talked about, the need to have innovation, to really crash the totally unacceptably high maternal mortality. Because you mentioned, and I agree with you, for every of these statistics is not mere numbers, but flesh and blood. And the truth, about it is the fact that now, and rather than before, MAMI is now looking at the entire sector-wide, approach, which means if we're really serious about crashing maternal mortality, it's not responsibility of maybe the health sector alone, it's the responsibility of the entire sector. That's why we looked at the sector-wide, and that's why we have the state desk officer or the coordinator for the sector-wide here. So you mentioned it, we had the community, the partners, the government. And when we say government now, we mean the federal government, the state government, the local government. So everybody now is coming together to see how we really need to crash maternal mortality. So MAMI, in nutshell, yes, it's a country strategy to crash maternal mortality, but it's looking at it from the perspective of bringing everyone together, not working in silos, but now we have to collaborate, to really bring down the ever unacceptable mortality.
Thank you very much, Doctor. To you, Dr. Suraj, Gombe is among the states engaging in this co-creation phase. What makes this initiative timely and important for Gombe's maternal and neonatal health outlook?
Yeah, thank you very much. Like the national coordinator mentioned, that is a intervention that is cutting across the entire nation, and Gombe is not an exception. And not even that, the statistic or the last National Democratic Survey shows that our maternal mortality is even higher than the national average, especially states in the Northeast. Our statistic has been, when you compare it to other states in the nation, we are having high statistic of this maternal and child mortality. Probably looking at the situation in the Northeast, the issue of insecurity might have contributed to that. And we have other socio-cultural factors and so on and so forth. All these contributing to the maternal. And it is believed that if we focus and tackle this issue of maternal mortality, we will as well contribute to the reducing of maternal mortality in the entire nation. And that is why the analysis that was carried out at the national level, they ranked all the local government in terms of how are they contributing to the maternal mortality. And in Gombe State, 8 out of our 11 local governments have been found to really contribute to this maternal mortality, which is, if you calculate the percentage, is a very high percentage. Even states with higher number of these local governments, like Kano, where out of 44 local governments, they have only 18 LGS that are contributing to that. So that is why we really welcome this development, and we, through the Commissioner of Health, insisted that the national coordinator have to be here to ensure that we got it right at the beginning in terms of intervention that will be carried out. And we're happy and we want to appreciate his presence, and it has really helped a lot, because our stakeholders now, they had all the information from the coordinator, and everybody is really very happy with this development. So I believe with this good start and timely start, we are going to make a lot of differences, and it is expected that maybe after 2 years of implementation, then Gombe State will not be having any of the LGS having this high maternal mortality. So that is why we welcome the development, and we are hoping that through his presence here, government will really commit a lot of resources so that this issue can be addressed squarely.
Okay, Dr. Sir, you've been here for the past 5 days, I mentioned earlier. What has the engagement with stakeholders looked like so far, and what outcomes are you hoping from this process?
Okay, so thank you very much. It's been since Monday, we've brought together. The state has actually been quite committed. I also must commend the commissioner and also the visit to the deputy governor. And I can see the commitment of the governor and the deputy and the entire government towards, ensuring that this, unacceptable statistics is reversed and declare better narration for Gombe, and which will contribute to the country narration. So since Monday, we brought everyone together. We have been engaging, taking them through the narration of what the statistics, has looked like. and then giving a detail around the MAMI strategy and what we hope, to achieve at the end of the day. And part of the strategy, actually, what we do when we get to state, when we say deep dive, and I must say clearly that the deep dive is part of the directive of the coordinating minister, Professor Muhammad Ali Pate, to say, you know what, it is good that we understand the context-specific cause and then of maternal mortality. So one thing we have done is to understand where do the deaths occur, which the desk officer mentioned. So we found that they occur in 172 LGAs across the country, and this LGA actually contributes 55% of maternal deaths. So if we tackle this headlong, it is clear, that definitely we will crash our maternal mortality by 55%. It's not that we're going to be neglecting the other LGAs, but we are saying that we demonstrate, this approach here, and then state government can then take it on, to replicate this approach in the other LGA. And I must say it's quite exciting when we paid the courtesy call to the deputy governor. He said to me clearly, even though you have identified 8 of our LGAs out of 11, but we're going to work in 11, which was quite impressive, by the government, and he said, and I must commend the government for taking that decision. So for us, knowing where they occur, we then decided, to understand the barriers to this maternal death, that leads to this maternal death. What are the delays? And so that's why we have to go to each of these states. We had focused actually in the first round to look at states with very high, LGAs, like you mentioned, Kano. We've gone to Kano, we've gone to Katsina, we've gone to Bauchi, Borno, and we've done Kaduna. Now we're in Gombe. And some other team are also in Kebbi, Zamfara, and Ondo, and then Ogun, just to have a feel of what it looks like in the southern part of the country. So the second day we go to the field, interface with the communities. We've gone to 5 communities, and in these 5 communities, it became clear to us, why the women actually died. We understand the socio-cultural barriers, of roles of the husband, the mother-in-laws, some religious beliefs that leads to maternal death. And then we understand the setting around the World Development Committees, which should play a role, in mobilizing the women. And we spoke actually to the religious leader, the traditional institution, and all of that. And of course, we go through and look at the facilities, and look at issues around the health worker, around the commodities, around the equipment, and we look at issues around the data, and we also look at issues around access and the affordability, because all of these are factors and barriers that can lead to maternal death. For a woman who delay in seeking health care, who had had previous pregnancies with hypertension, it is very unlikely that if you don't pay attention in the new pregnancy, she might likely go into a tweak or have seizures and all of that, or the one that has previous bleeding might likely to. So if they delay, that will be an issue. And the delay is not that the woman is not willing, but perhaps he needs express permission from the husband. So all of these things, of course, have come clear, with this. And then we looked at the facility. There is no enough health workers, but some have some, and we also don't have enough community-based health workers to track the women and ensure. So all of these things, I think we do the second day, and then we then look at all of these problems and try to find solution around them. And so, and with all of these, we then come up with what we call the action plan, MAMI action plan, which we present actually to the commissioner and his entire team. But even sometimes we present to the deputy governor, who is the task force lead, for the state. So then we look at implementation. The other thing we also try to do is to cost this, and then begin to look at where would the government, have provisions in the annual operation plan, and what is the gap? which we as the SWAP coordination office, under the office of the coordinating minister, we then see how to mobilize resources to bridge the gap, either from the federal, from the partner, from all the other stakeholders. And so this is exactly what we do for the period that we are in the state. And I can assure you, with the plan that we outlined, which we looked at yesterday, which we are going to cost today, it is clear that we can actually crash. And when I mean crash doesn't mean from 5:45 to 5:12. That is not crash. Crash means from 5 to a single digit. We are quite ambitious, but we believe it's doable. Because when you say, it's 5:45 to is an improvement, who wants to be in the 5:45? Who wants to be in even the 10, even if it's one? Whose daughter wants to be in that? Whose mother wants to be in that, or whosoever? So we say that it is actually not make sense for a woman to die bringing another life. That's it.
Sir, Dr. Suraj, from the state perspective, what are some of the key maternal, although the doctor has mentioned some, the key maternal and newborn health challenges that MAMI we expect to address once implemented?
All right, like he has highlighted, in this state, we are looking at various barriers that are contributing to the maternal and neonatal death. So from various areas, if you look at the level of the family and the community, I can say we have those cultural beliefs and sometimes issues to do with allowing our mothers when they are pregnant to visit antenatal and to deliver. Not even issue of antenatal, but it has to go beyond. After registering for the antenatal, we have seen a lot of improvement in the antenatal based on the last demographic survey that was released. We have seen that we have moved from around 32% to 47% in the state. So we've seen a lot of improvement in that. But where we have not made a lot of progress is in terms of facility delivery, where they will be supervised by skilled health worker who will supervise the delivery. Because some women will come and register, but they will not come back to deliver in the health facility. So this is one of the issues that we feel this MAMI program will help to address that gap. So that using the community health workforce and community and religious leaders, we are going to ensure that these women now will come back and deliver in the health facility under the supervision of skilled but attendants. So this is one of the areas. Then when you now look at also the level of the facilities, we are looking at the facilities readiness. These facilities, we call them BIMO, that is facility that provide basic obstetric care. So analysis has been done and it was found out that some of these facilities are not fit to receive these pregnant women for delivery. And the government has put mechanism to equip those facilities so that the facilities will now provide all the requirements that is necessary for a woman to deliver. So that is one another area, which right now we have around 86 facilities. The executive governor has given an approval and funds have been released to upgrade or to revitalize this facility in the state. In addition to that, federal government are also renovating across the entire nation, which Gombe State have also been, some facilities have been identified for revitalization. And not only that, we ensure that those BMOM facilities, they have all the necessary equipment that are required for receiving a safe pregnant delivery and so on and so forth. So that is another area.
So could you explain what that BMOM is?
Yeah, BMOM, basic obstetric care, is being provided, whereby if a woman is in the facility, we expect that we have a minimum number of personnel that are available there. We expect one midwife who is trained to provide those services. We have community health workers, at least 3 of them, one midwife, 2 midwives, 3 community health worker, and then some other staff. But right now, if you check some of these facilities, we rarely have one full complement that is expected of that. So the BIMON facilities, they have the requisite human resource, they have equipment that are required, good delivery bed, delivery tools, and so on and so forth. They are available in that. And then the drugs, supplies, they have to be available so that whenever there is any emergency, immediately it can be provided to those. Not that if a pregnant woman comes and we check her motion, she's having eclampsia, so we have to start looking for the drugs. Before you come back, something must have happened. So in Bimon facility, all these things are ready and just waiting for that. So in terms of even the arrival of the woman to the health facility, that is a big issue that we are experiencing in the state because of the delay that is experienced between, especially in the rural communities. We hardly get a woman arriving on time. Before they read, maybe if she's bleeding or having eclampsia, the delay that is being experienced is something that MAMI is trying to address, because there's going to be provision for a voucher, or that is money that will be given to road traffic, Nigerian Union of Road Traffic Workers, who will be engaged and across all the 8 LGAs that MAMI will be supporting. And not only at the LGA level, even at the ward level, they will be engaged, at least 5 of them, the road traffic workers. So when they are engaged, they will now be giving the pregnant woman, by the time she is registered, she will be giving a voucher, so that any time emergency starts, they will now be transported with those arrangements so that they can get to the health facility on time and intervention can be done at that level. So in addition to the BIMON, we have what you call CIMON. The CIMON are the secondary healthcare facilities that will be linked to a BIMON, so that whenever the BIMON cannot handle such emergency, then they can quickly transfer the patient to the secondary healthcare facility, that is the CIMON site, where we have doctors and some other people that are higher than the BIMON facility. And in that, the requirement for that, we must have a minimum of 3 doctors that are endorsed providing maternal and child health services. Where we have, there are issues with the neonate, they can easily be handled by a medical doctor in that facility. So they are called CIMON, that is Comprehensive Emergency Maternal and Neonatal Health Services, that is the CIMON. So across all our 11 local government, at least one secondary health facility has been identified to provide that. So not only that, even cesarean section in those 11 health facilities, that is the BIMON site, the CIMON site, they are going to provide free cesarean section. That is for women that are in need of that, because we found out that majority of people, the cost of cesarean section can be a barrier for them to be to access services. So that is why federal government, under the leadership of the coordinating minister and the MAMI, they have now given that as a free of charge. And we want to use this opportunity to call on our people in the state to be aware of this development, so that right now we have only 5 that are activated, but the target is to cover all the 11 local governments. So now we have 5 secondary healthcare facilities that are providing free cesarean section. And these are Specialist Hostel Gombe, Gombe State, the teaching hostel, federal teaching hostel, the maternal and child health hospital in Gombe also, and then we have General Hostel Kaltungo, General Hostel Bajoga, and General Hostel Duku. So for now, these are the hostels that are activated, but before the end of this year, all the hostel will be key into that, so that people should access free cesarean section, which will be given free of charge by as provided by the Federal Ministry of Health under the leadership of the coordinating minister.
So are there criteria for that? Or any woman that comes into this 5 hospital will be offered this?
Yeah, once she's in need of that service. Yeah, once he's assessed and found that yes, she is in need of emergency cesarean section. But for people that are doing elective, I think that one maybe I'm not very clear about what happened. But I know for emergency, it's supposed to be given free of charge, because that is what is.
So even if it is elective, so long as there is a need for it, for cesarean section, for the facilities that have been mentioned, the people should take advantage of it. A woman in need, so before it was to say indigent, how do you, so we found out before you could qualify whether she is indigent or not, that might be an issue. So if this woman needs cesarean section right now to save her life and her baby, it just needs to happen. What I mean by elective is that, for example, a woman who has had 2-3 cesarean section of previous cars, who had delivered by, who are in her life has never delivered normal, so it might be elective, but she needs, if she can't afford it, then it has to be, done at these facilities free of charge, prepaid, which is going to be prepaid by government, so it's part of the president's initiative to say, let's also bring succor, to the, and as I speak to you, over 4,000 have been done since we started, January, by the National Health Insurance Agency, so they've done this, across the country.
So, MAMI actually is cheering news. It's actually a news that when a pregnant woman hears, she's calm, even the community. But how would you ensure that it is not just a policy?
No, it's not a policy. I've just told you it's not a, here is it. It's not a policy. If it's a policy, 4,000 cesarean section would not be done. If it's a policy, we would not be here. If it's a policy, we will not co-create with the state to ensure sustainability. So if it, and I don't even think you mean policy, you mean politics. So, so if you think it is politics, because you need to look at the political will of the president, and part of the political will is getting the right peg in the right hole, getting the coordinating minister, to be on board to drive this process. So one thing is to have a vision, another thing is to have the right person to interpret your vision, and then having the right set of people to drive the processes, to say, well, yeah, let's make this happen. So we're talking about lives here. And I can tell you, for every of those protruded belly that you see, it is 1 plus X lives. It could be a singleton, meaning 1. It could be twin, it could be triplet, it could be quadruplet, it could be so many. So for that passion, that's why we just don't want to play politics with this. It is not mere, statements. So that's why I said, so we've come up with, we know quite well what are the barriers. One is mentioned, I mentioned the sociocultural, I mentioned the one that has to do with the delay in reaching, that's transportation, which you alluded to right now, and then in receiving. So now, let me tell you why it is not a politics. As we speak now, the president has released funds to the National Primary Health Care to revitalize, the BMONC center I was talking about. And what do they mean by BMONC? To get them to level 2, meaning they will be open for 24 hours. They will be able to perform all the 7 signal function tests, and to also, that's National Primary Health Care. Also, for CMONC, it's compact signed, by the sector-wide approach. I think I didn't dwell so much, around that. Sector-wide approach, when the president said, if we actually truly must reform our health sector, nobody can sit on the fence. It has to be collective responsibility of all, and that means from the federal government, state government, local government, everyone all hands have to be on deck. And so in line with this, they signed a compact to say that we are going to work together. And that moving forward, we are going to adopt a sector-wide approach, meaning we will have a one plan, we will have a one budget, we will have a one conversation, and then one report, one conversation, and one voice. And what do we mean by one plan? From the health sector strategy blueprint that has looked totality of all of this, all this has been taken very care of, to say, part of the thing is to look at, population health security, and all, and then even the what's it called, presidential initiative, the one we call PVAC, to say we must manufacture our commodities locally to reduce the cost and then make it affordable for the people. So all of these are in the health strategy blueprint, and then the state government agreed to it. So in the annual operation plan of each state, they draw from this blueprint, to come up, because we have agreed that this is what reform our health sector, improve life of citizens, make them more productive. So in line with this, every state government agree and they sign that compact, meaning we can't deviate from this. And then we pull resources together. And the coordinating minister has been so, energetic in doing this, moving around to see how resources could be pulled together from partner, and I must clearly, say that that's why I say it's not mere politics. The president has committed so much, to the health of the people. You recall, even with the U.S. government withdrawal from all of this, the president has stood up to the occasion to continue to put resources to say, never should our HIV, AIDS, TB, malaria, people be left alone. After the U.S. government pulled off their funds, the president came up to say, put this in to bridge the gap, and then we'll see how, none of these people go out of drug. So in line with that, they agree that for each of the local government, there will be one CMONC, which is part of the compact. Then there will be a BMONC, which will be in every, ward. And then in line with that, funds have been released. As we speak today, I think over 1,000 of the BMONC has been revitalized, meaning to function, level 2 function. And for the CMONC, work is going on to get, in fact, in 3 weeks ago, the dissemination of the CMONC assessment to commence the process of revamping, the CMONC facilities, has been done. So that's why I say it's not mere, politics. And of course, let me tell you, from maybe next week now, women will be getting to the facility free of charge with a voucher that he mentioned. In some of we're starting with some states, and then we move it on. And to tell you, some commodities have been moved from the National Primary Health Care to come to the state, to go to the PMONC center. If they move the women there, you must be able to have access to commodities. And the other aspect we are working on in conjunction with the state is to really do mapping of the community health workers, who will be at the community, to track the women, which was one of the things we found out. Some women will still want to go for antenatal, but unfortunately they don't come and deliver, So how do we then ensure that we track them, do a proper back plan for them? This woman will deliver in June the 1st. You must keep tab on her to make sure that she comes back to the facility to deliver. Because it makes no sense for them to do antenatal and then deliver at home. So, and we have engaged the traditional institution religious leader. Because one of the reasons is that, yes, a typical Kanuri woman wants to sit back and demonstrate her strength and then to deliver at home. So they said if a Kanuri woman goes to the hospital, they said this one is weak. So we have to dissuade them from all of those acts that can lead to their death. So we are engaging the community leaders, we are engaging traditional institution religious leaders. We are also going to strengthen the world development committees, to begin to look at all of this and make sure the women don't ever have to cause, to deliver, at home, because we cannot ascertain the skill of those women. who are going to be taking delivery. Much more so, we found out that they are co-wives. We just ask them to push. And some of the presentation, maybe the baby is coming with the buttocks. And if you have the woman to push, you only can rupture the uterus. And by that happens in the middle of the night, and there is no transportation. So before the woman could get the next help, she has bled out the blood in her. And so this is what we're trying to avoid. So if you come to facility, we track, ultrasound will be done, so we know the presentation. We can continue to know this will require a cesarean section. And you will not be limited to that B-monk again. Your case is getting to the C-monk that he has referred to for cesarean section. So all of these are properly thought through, to ensure that no woman actually should die, and the newborn anyway, for no justification. Yeah, we understand clearly some of the deficiencies. For example, I'm just giving you highlight of the fact that most of the facility don't have a newborn corner. So if a child is born with asphyxia or is preterm, how do you ensure that that child is warm in the meantime? So these are things we are going to be fixing. And I tell you, there's a whole lot that will go through, that will come in terms of training to improve the quality of care. And the beauty is that, so we are rallying the partners, the government is putting resources to ensure that all this, health workers are skilled, to be able to deliver and discharge their duty.
So we would say that is part of the renewed group agenda.
Correct. So absolutely. So that's actually the truth. It's hope for the mothers, hope for the newborn, and hope for the entire country, as their husbands who are happy to see their baby and their wife alive. And grandmothers.
I'm so happy. I've seen health fellows. What is the relationship with health fellows and the MAMI? Are they also part of the MAMI project?
So health fellows is an innovation of Mr. President to say, bringing people, this young, talented, brilliant youth together that are employed, to say, for once, let those one who know no one have the privilege in their life, to be able to even get an opportunity to serve their country. And what do I mean by that? You and I know that it takes a lot, for people to get jobs these days. You need to know someone. But I tell you, the crop of fellows you saw, or that are in this state and across the country, they were picked one from each of the LGAs, making 774. By mere test of their capacity, nothing more. No letter, no link, nobody, knew no one. It's just a way to say, let's even start somewhere, where, merit should not be trashed in the bin. So these fellows, have been nominated, of course, so invitation, a request was called for people to apply. So those who have been applied were screened and shortlisted, and those final ones were the one that made it for the orientation, in Abuja, and they actually met with Mr. President, where he even promised them, and it's part of the Renew Hope anyway, that for all of you, you'll be hired, but so they need to do well. So that's the precondition, the only precondition, that's your own if you don't do well. So what we're saying is that if they are in each of the LGAs, then they can contribute, to either, reducing the barrier of seeking health care by talking to the community leaders, or going to facility and then contributing there, or even in terms of data and governance, or, in terms of, talking to even to the NURT as one of them has done actually, looking at how to really counter all the barriers. So they could pick interest in any of these and develop a project at the end of the year, and whichever project they write, we also contribute, to improving the health sector. So that's why, so for 8 of the LGAs, that are MAMI LGAs, each of the fellows that are in those LGAs are the ones you've seen here. But what we have even done is that to bring all of them, so that whatever is happening in this 8 LGA also happen in the other LGAs too. They can begin to talk to the people. Yeah, they are the 11 of them that are there, and from the entire, state, LGAs.
Okay, sir. With MAMI still on the preparatory state in Gombe State, what should health workers and community members expect next?
Yeah, what they should expect is that in the plan now that we are developing, we looked at the current status, which newer things are on the way in terms of their capacity. So we expect that we will continue to build the capacity of health workers so that they are in tandem with the current things, the current status of things, whereby their capacity will be built so that they provide the most qualitative services that is expected to be delivered to the pregnant women and unborn child. So capacity building is one. So that is it. Then another thing is in terms of incentives, they need to be motivated. We plan to set sort of like a competition, so to say. People that have done very well will be recognized.
Okay.
And they will be given reward in terms of even we arrange in such a way that it will be known that yes, their work will be seen by everybody that they are doing very well, and sometimes even some things will follow as an incentive. So this is something that we have not been looking at that in the past, and with this plan now we want to start that program that will help in recognizing those, and then people that are not doing well as well, they will not just be left like that, but there will be sanctions against them so that they do the right thing. And we're happy that in Gombe, with the biometric programs that is already ongoing, the problems of absenteeism has been so far addressed. So we feel that now the performance aspect will now be looked at so that health workers will do that. And so there are other things that is part of the plans, which we believe if we have all the commitment and funding, it is going to really go a long way in ensuring that the health workers will have their capacity built.
So, sir, as someone who is deeply involved in state level planning, the DAPR is in the State Ministry of Health, what is your personal hope for what MAMI can change in the lives of women and children?
I'm very much, like I say, hopeful that things are going to change soon, because we have never got it in this way before. For us to go deep dive into the issues of maternal and child health. In our previous plans, we usually don't go into deeper and identify the root causes of this maternal death. So for the first time, we've interacted with the pregnant women. We had their own views regarding their perspectives regarding this, the causes of maternal mortality. We interacted with the community leaders. We interacted with the health workers, and so many people. We had their own perspectives. So with this now, then we now develop interventions that are going directly to address those root causes. So that is why I'm very optimistic that this plan for MAMI is going to work, and we're going to see a lot of good results as we start implementing.
And National Coordinator, sir, what gives you confidence that this collaborative model, starting with my Gombe State, will lead to measurable reduction in maternal and neonatal deaths?
So that's the beauty of co-creation. So we didn't sit in Abuja to say, send midwives, like we did for the MSS, or send commodities like we did for the Saving a Million Lives. So now we're right here, and I've told you, over 10 states now, and we're going to 33 states that we think really are the problems. So with all of this, I have not, and of course we're able to also elicit the political will, for that we drive all of this. I told you what I heard from the Deputy Governor, the commitment of the Commissioner and all his entire team, is clearly a clear demonstration of the fact that when we hand over the plan to them, they will be good to go. And that's why for us, from the sector-wide approach, we are trying to see how funding won't be a barrier. So we would come, on the table to say, we know you have the capacity, you have this in your annual operation plan. How much of it are you able to put down? And then we can match it, with this for proper implementation, and then we can see the crashing of the maternal mortality. So I think for me, what I've seen so far is clear demonstration that yes, this will happen. And with the fact that the governor also has committed a lot, to the health, since he started his administration. So I'm sure when he gets to have this plan, he definitely will run with it. So with that, we're happy, and this is why we are here, in Gombe. And then of course we go around to see that same thing happen across the country. So the state government needs to actually support the federal government in truly renewing the hope of the people.
So as we wrap up, what advice do you have to the people of Gombe State, the health workers and all involved in MAMI projects?
All right. First and foremost, my advice is to follow it in those categories like you mentioned, starting from the health workers. We cannot succeed in this plan, no matter how good it is, without the health workers doing what is expected of them and the right thing that they should do. So my advice is we need to be very much committed, whatever that is given to us, and say, okay, do A, B, C, D. So we need to do it with all our dedication and commitment. So that's my call to the health workers. So we need to be around where we are providing 24-hour services. Health workers must be there, because there will be instances when they are not there, emergency will come and nothing will happen. So that is my call to the health workers. Then secondly is to the community religious leaders who have been contributing a lot in the health sector. I remember in the area of some diseases condition like HIV, immunization, and they have contributed a lot to that. So with this plan now, we have given them a very big role to mobilize the community and ensure that a lot of people are aware of what is happening. Because without awareness, then services will not be accessed. So they will support us towards creating awareness in the community, talking to the husbands and the rest, so that where we have issues of not allowing women, so one husbands to be giving to give their wives like approval that whenever they are in need to go to the hospital, they should just go without really waiting for that, saying, okay, I'm waiting for giving the permission to go. So that is one of the key things that we want, the support of the families, communities, and religious community leaders. So in terms of what we are requesting is the support of the government, both at the state and the local government, particularly local government who are very close to the community. So in the past, we have not, with this plan now, there are roles that local governments are expected to play for the actualization of these plans. So we are calling on them to put in resources so that those activities will be supported and implemented at that level. And then the World Development Committee, we already planned that World Development Committees are expected are going to be strengthened. Their capacity will be built, and a lot of activities rally around them. Without their support, all those issues cannot be addressed, especially in their relationship with the community health providers. So the World Development Committee, community health providers, they are the ones that will now ensure that the pregnant women are accessing services. So we really expect a lot at that level. So we are also calling on them to give us that support. Even the NURTW, who will be engaged with transporting the pregnant women, and that is why we ensure that we follow through their unions for effective coordination of that program. So we are also calling on them to give us maximum support, and that is what we are expecting, and we are requesting for that support.
Sir, your final message to the people, especially those who think maternal and neonatal health are not their concern.
It is concern of all, I must say, and it is not responsibility of one individual or one sector, particularly health sector. It is responsibility of all of us, right? Like you rightly said, mobilizing the women from the community to seek health care on time, transporting them, to the facility, and then making them receive the right quality of health care. This is responsibility of all of us, and of course ensuring that the woman also go back for the postnatal, for the immunization of that baby, for everything that has to do with nutrition of the baby, monitoring their growth. All of these are things that is responsibility of all. So now we talk more about the male involvement, because we also need them to also give the consent in terms of family planning, which is integral part of MAMI. Issues around the adolescents, because we really don't want the teenage pregnancies, which often leads, to maternal death, contributing quite a number of the maternal deaths. So all of this, that's why I say responsibility of a religious leader, traditional institution, they have to play a lot of role. Yes, government will continue to revamp the health facility, recruit more health workers, provide commodities, and get equipment. That's the responsibility of government. But for the health workers, they need to do their own bit. If you are supposed to be available and you're not there, it definitely will lead to maternal death. It causes a lot of delay in receiving health care. The other aspect that if you know this is beyond your own scope, ability to refer on time, it's also important. And when there's going to be a referral, the provision of the ambulances and all this referral, are things that, as government, will need to be taken care of. And so for me, there is no one person. In fact, the education of a girl child is also part of it. And then the need for the Ministry of Works, the Ministry of Women Affairs, to be part of the empowerment of the women so they can take some decision and then be able to even do some things without having to really wait till the husband come back to give them transport money to go to the ANC. So all of this, so that's why I said it, and of course getting the road network clear. Of course, community leader, there's a lot of community can do. The community we went to, I told them about linking up with the Community and Social Development Agency, for them to get some help. They can do a lot for them in doing the perimeter fencing of the hospital. They don't have to wait for government, to do that. So all of this, all of us have roles to play in crashing maternal mortality. That's the difference in the approach that we have always done before. Now we are looking at the sector-wide, entire whole of the sector, getting involved. So now we look at the primary health care, the national primary health care, the state primary health care, the national emergency services, the state emergency services. We look at national health insurance, the state health insurance, the Go Health. So everybody again has to be enrolled, so that when it is not when the unfortunate situation happened, they'll be looking for funds. And I didn't add, other than that, those who get the cesarean section also get automatically enrolled into the insurance program, and their children, then they can all benefit. So all of these things are things that we're looking at, and I have no doubt in my mind that I represent this activation plan, would truly will ensure that pregnancy will no longer be a death sentence in Gombe, and the children can live beyond the age of 5, and by extension the entire country. And I look forward to a great collaboration. I want to sincerely on this note thank the government for their role, and all of us, including you, the media. I told you the other day you have roles to play, getting the right narration, to the people, and also use your medium to also mobilize, the women and the children to come to clinic. So I thank you.
Thank you very much, Dr. Dayo. Viewers, it may interest you to know that Dr. Dayo was one time the Commissioner of Health in Ondo State. So he has the feel of what it means to be at the grassroots before raising to the national level. So we believe MAMI is in a safe hand. As we have heard today, saving the lives of mothers and newborns is not just a job of government. It begins in our homes, continues in our communities, and strengthened by support from health workers, leaders, and development partners. MAMI may have started with meetings and planning, but its true success lies in what happens in our neighborhoods, in our places of work and worship, in marketplaces, and in gatherings. We believe that MAMI will save a lot of women from preventable death. So let's be part of this change. Encourage antenatal care, support skilled birth attendants, educate our girls' child, and speak for safe motherhood. Whether you are a parent, a traditional leader, a youth, a health worker, your voice, your action, your care matters. To our guests, Dr. Dayo Adeyoju, thank you for coming.
Thank you so much.
We will follow up, as you said, as journalists, we will follow up to see if this actually is implemented. Thank you so much for coming to Gombe, and thank you for what you have been doing. Dr. Suraj, thank you so much for being with us here in the studio, and we are glad that you made insightful contribution, which is actually cheering news to pregnant women. So as you return to Abuja, we pray for safe journey, and as you engage in activities to save mothers and children, we pray that the good Lord will help you and succeed in this program. Thank you very much for coming. Viewers, we have heard our health is in our hands. Stay tuned to GMC TV for more insightful programs. Thank you.